all of you for being here. And thank you again to WFNS. And as I said, especially Salman Sharif and all the organizers for having us here. Thank you.
Thank you very much, Global Neurosurgery team, for such a great session. And thank you, Dr. Tarek and Dr. Chloe, for moderating this session with us. Now, moving on, we have another peripheral nerve session. So I would like to call upon Dr. Nasser El-Ghandor and Dr. Lucas Rasolek to turn on their mics and begin the moderation of this new session. Thank you.
Greetings to everyone from Belgrade. I hope you hear me. We are running late with the program, so we'll be fast and furious like always when we are presenting as a peripheral neurosurgery group. It's my great honor and pleasure to introduce first speaker, keynote speaker, Dr. DEBORA GAROZZO from United Arab Emirates. She will give us a lecture about management of brachial plexus injuries.
Hello? Can you see me?
Yes.
Can you see also my screen?
Not yet.
Okay, 1 second. Can you see it now?
Yeah, now
Is it on?
Yes.
Okay. Okay, so first of all, thanks so much for the invitation and for the opportunity. My talk is going to be a clinical talk about the management of brachial plexus injuries. We know that brachial plexus injuries are traction injuries that occur mostly in cases of motorcycle accidents, and this explains why the majority of patients are young males between 15 and 35 years of age. The epidemiology of brachial plexus injury is probably not correct. Currently in the literature, it's underestimated. We actually have a progressive escalation of these injuries worldwide, and in particular in Southeast Asia. Now, something which might be difficult for a young neurosurgeon is actually to clinically evaluate a brachial plexus injury after a trauma, because these patients are most of the time multi-traumatized, and therefore the neurological evaluation may be also quite difficult. So there are a few tips that I'm trying to give that young neurosurgeons could keep in mind in order to be able to diagnose these injuries. First of all, the presence of bone injuries of the upper extremity, and also considering that the detection of multiple fractures of transverse processes and lamina may be suggestive of root avulsions. Clavicular fractures are also quite significant because they are usually associated in high percentage with brachial plexus injuries. And keep in mind that up to 20% of patients present also vascular injuries. This can be, of course, clinically detected by abnormalities of the distal pulsation of the wrist, presence of hemorrhages and ischemia in the upper limb, hypovolemic shock, and of course require urgent diagnostic workup and urgent surgery. Another thing that you can see is the presence of an Horner sign consequent to the injury of the stellate ganglion, and sometimes the Horner sign does not appear immediately but can appear 24-48 hours after the traumatic event. Now, the main thing is that, of course, we need to differentiate the Horner sign with the anisocoria in head injuries, and of course, neurosurgeons will consider that it has to be consistent with the CT scan findings, but also a good trick is to keep in mind that the mydriatic pupil is well reactive to light. This is an chest array that may be consistent with the palsy of the phrenic nerve, and again, suggestive of brachial plexus injuries. And a small percentage of patients with BPI may present also an incomplete Brown-Séquard syndrome, which is consequent to multiple avulsions and the intramedullary hemorrhage and lung tracts damage. Now, the vast majority of patients with brachial plexus injury, unfortunately, do not recover. And this is why when you first assess a patient, you have to try to understand whether the lesion is date. So when we assess the patient, we have first to try to classify the injury pattern based on the type of motor and sensory deficit, but we also must focus, and this is probably our main purpose, on the presence of root avulsions. In neurological evaluation, we should always focus on the motor function, which is our most important parameter. And especially for those that are starting to work with brachial plexus injuries now, I would consider that it's very useful to use the Merle-Dobini assessment form, because it helps you also to understand which are the roots which are involved. Once we have understood what kind of injury pattern we have, we can distinguish between supra and infraclavicular injuries. Supraclavicular injuries for 25% account to upper plexus palsy with C5, C6, and C7 injury. And what we see is a patient that presents a loss of shoulder movements and biceps function, and may also have a wrist drop in those cases where there is also an involvement of the of C7 and consequently a loss of the extensors. The presence of a lower plexus palsy involving the lower roots C7, C8, and T1 is fortunately only present in 3% of cases. These patients present a loss of the fine movements of the hands, and they usually have avulsions of the lower roots. 30% of patients present infraclavicular plexus palsies with high frequency of vascular injuries. And in these cases, the clinical presentation may be quite difficult, especially for the inexperienced physicians, because it's rather variable depending on the cords which have been involved in the process. The majority of our patients are anyway patients that sustain a damage on the old brachial plexus, and consequently they have a flail arm. They have lost completely the function of the upper extremity. Now, when we assess this patient, we mainly have to try to understand whether the brachial plexus injury is a pre or a post-ganglionic injury. And we keep in mind also that when there is a root avulsion, there is also the formation of a meningocele. These root avulsions are extremely common because they are found in more than 70% of brachial plexus injuries. And we can actually already suspect that clinically, and then we have to confirm them with the imaging. Now, we have already seen some of the clinical signs of root avulsions, but there are still a few more, which I will illustrate now. The palsy of the rhomboid muscles, the palsy of the dentatus anterior, which consequently results in a winging scapula, and is consequence to a damage of the Bell's nerve, which takes origin from C5, C6, and C7. The presence of an external meningocele, which obviously is related to a significant injury with multiple avulsions, and is fortunately only in 3% of cases. And then another clinical sign suggesting the presence of avulsions is deafferentation pain, which is a peculiar form of excruciating neuropathic pain, just related to the root avulsions, that is described like a persistent and continuous dull pain associated with occasional paroxystic painful electric fits. When you have a patient with a brachial plexus injury, there are three main things that you have to try to follow. You have to prevent degenerative changes in the shoulder joint, and this is why we offer the patient a sling to support the flail arm. We have to recommend daily physiotherapy aiming specifically to prevent the development of ankylosis in the joints. And pain control is extremely important, considering that in a study done by myself, but also there was a similar study done by Lucas, it has been very clearly demonstrated that patients are more concerned about pain, that consider it decreases their quality of life more than the disability. So we have a wide spectrum of drugs. The first choice nowadays is usually Lyrica. Keep in mind that opiates are extremely effective, but especially risky because they may imply the risk of addiction. Once you have assessed the patient clinically, then you need an assessment with investigations to confirm or rule out the presence of root avulsions. EMG and nerve conduction study are certainly useful, but we have to say that the core of the diagnostic assessment nowadays are certainly neuroradiological investigations. We usually prefer to apply a protocol that includes the myelography, the neurography, and the DTI. So once you have studied your patient and you have understood whether the patient has a brachial plexus injuries with or without avulsions, then you have to decide the timing for surgery. If the clinical assessment suspected root avulsions that were confirmed on the imaging, then you have to give indication for surgery as soon as possible, because wasting time is actually only detrimental and only provides more muscle degeneration. If the investigations do not confirm the presence of root avulsions, if it's only a postganglionic injury, then the patient has to be clinically and electrodiagnostically follow up to 3-4 months. But then if we have no signs of recovery, surgical indication has to be advocated. This is a short overview. And I would suggest that if you have difficulties in studying the peripheral nerves, you resort to the atlas, to the 3-dimensional atlas of neurological surgery by Dr. Thomas Pirev. Follow us on our social media, and thanks so much for your attention.
Congratulations on time, Nasser. Are you here?
Thank you. Thank you.
Thank you. Thank you very much, Deborah, for this very unique presentation. Would we move to our next speaker, Christian Hinem from United States of America? She's speaking about USA in the assessment of peripheral nerve surgery.
Germany, almost United States, but more or less this is
it's mistake.
We are same family in the peripheral.
Okay.
Yeah, well, so first of all, thank you so much for organizing this amazing event and letting me in. As Lucas pointed out,